Hi, I'm Dr. Robert Glatter, medical advisor for Medscape Emergency Medicine. Joining me today to discuss a novel way to treat pain related to conditions such as rib fractures and burns is Dr. Sergey Motov, an emergency physician with expertise in pain management and research director in the Department of Emergency Medicine at Maimonides Medical Center in Brooklyn, New York. Also joining me is Dr. Gary Schwartz, vice chair of pain and anesthesiology at Maimonides Medical Center. Dr. Schwartz is board certified in anesthesiology and interventional pain management. Welcome, Sergey and Gary.
Thank you, Robert.
Thank you, Robert.
It's a pleasure to have you both. Sergey, we were chatting earlier this week and you had mentioned a novel approach to treating a common condition we encounter in the emergency department, rib fractures. As we all know, they're very painful. They can lead to pulmonary complications, including atelectasis, pneumonia, due to splinting and lack of proper pain management, along with the use of incentive spirometry. So, Sergey and Gary, can you describe traditional approaches to alleviating the pain associated with rib fractures? What do we typically use? And then we'll get to some novel treatments that we're here really to discuss.
I'm going to use the emergency medicine approach to rib fractures. Pain of, as you pointed out, of utmost importance. And with advent and sort of, acquiring amazing technique of interventional pain management, the physicians, for the most part, are very astute of providing nerve blocks to alleviate pain, at least in immediate need. I'm talking about a relatively short term, 1, 2, 3, 4, 5 hours or so for an emergency department. And primarily we focus on fascial plane blocks, such as serratus anterior plane block. Traditionally, the physician don't use much of the intercostal blocks. At times we can direct a spinal block to cover the lateral aspect of the chest wall. Part of the multimodal approach, we of course can use NSAIDs. If there's a contraindication, we can use opioids. There's some data that you might consider using topical formularies such as lidocaine patch that is semi-conflicted. And then the question becomes what an innocent patient home with. And again, traditional teaching is either opioids, immediate release with a short course, plus minus NSAIDs, plus minus acetaminophen. The issue with the rib fractures is that while we can manage immediate and super acute pain presentation in DD and not just charge up to, 24, 72 hours, what happens afterwards, it's very challenging because acute intercostal neuralgia related to traumatic rib fractures, it's semi-manageable. But if it's poorly treated and inappropriately treated, I would say, it has a great deal of tendency to transform into chronic intercostal neuralgia. It contributes a great deal of disability and morbidity. And me personally, I came across several years ago, and I'm going to refer to Gary, of entity called cryo-neurolysis. Cryo, cold temperature neurolysis, freezing the nerve. And I know for the fact, and I'm super excited to be here today, that Gary is the one who's pioneering, championing this technique in our institution.
Gary, I'll let you describe this. And really, what do you see as the main role at this time in 2024 for this procedure?
Well, as Sergey alluded to, the traditional approach of opiates has side effects, constipation, obviously addiction, tolerance. And unfortunately, a lot of these rib fractures are due to a lot of older patients. So they come in anticoagulated, so they can't have NSAIDs. So Sergey and his team in the ER has been pioneers in giving short-acting local anesthetic blocks that could last anywhere from 12, 18, 24 hours. There's long-acting local anesthetics that we can get out to 72. But unfortunately, these rib fractures and the pain associated with this, in addition to the intercostal neuralgia, could last weeks to heal. That's where cryo comes in. So we're all used to ice or cold temperature. If your child ever gets an earring, what do they do beforehand? They put some ice on their earlobe. It numbs it up. They don't feel pain. It allows them to get their ears pierced without pain, but it's short acting. So what we have now is we have handheld devices with tips about as long as a pen, 3.5 inches, that you could go down precisely to these intercostal nerves that innervate the ribs and give a lesion, a cold lesion that freezes these nerves. The benefit of it is it's not permanent, like cryoablation, like we've seen for tumor necrosis, which destroys outside tissues. It's really a small lesion, about 16 by 8 millimeters, which is enough to engulf the nerve and pretty much stun it. So it causes axomatesis, but the epinorium, the endonorium, and the perinorium, the inner workings of the nerve, stays intact, so it regrows. It just really destroys the myelin sheath and the axon.
So you're creating a scarring effect? Is that what you're saying? In other words, you're doing a cold temperature freeze, you're stunning the nerve. My question is, does it regrow? I mean, is this a permanent type of injury?
So back in the day, I think it's been many years for all of us, Wallerian degeneration, nerves do regrow after injuries. Unfortunately, you two probably see in the ER for big traumas where the nerve is transected, those unfortunately grow back. This is considered a grade 2 lesion. So the Wallerian degeneration recurs. So the nerves grow, depending on the literature you look at, about 0.5 to 2 millimeters a day. So this intervention gives us at least 3 months of relief for the patient, which is in the time frame where the rib fracture will heal, hopefully no damage to the nerve from the fracture, and they go on living their life without having to take opiates, without having to stop their anticoagulation. Because prior to this, when I was a pain fellow, we used to put epidurals in a lot of these patients. The problem with that is they can't go home, and if they're anticoagulated, you can't place it for the risk of a spinal hematoma.
This is something we encounter daily, and certainly those patients who have more numerous rib fractures that have flailed chest could even be more devastating, those that get intubated. Do you see any role in terms of ventilator weaning using this technique specifically in the ICU setting?
That's an interesting concept. So I'm not sure so much about ventilator weaning, but we've used this in the hospital for rib fractures from traumas where they had such severe fractures where they had to go to the OR for rib plating, where they did necessitate an epidural. And we've used this to transition to DC their epidural and transition them to get the patient home. I think that is part of the care, not only in the ER, but in the hospital as well. We need to treat the patients, but we also have to have a transition plan to get them out of the hospital. Not that we don't want to treat our patients, but we have to have a plan to get them home. I'm guessing that might be an interesting stage of research in the future if it does help with weaning from a vent.
There are some studies out there, to be honest with you, that there can be some utility in terms of vent weaning using this technique. The ability of this to change how we manage pain is just incredible. Sergey, in your opinion, do you feel that this is something that you could implement in your ED with your patients in the near future?
Definitely. And I have personally been very big proponent of it. I'm the theoretist because I've covered a great deal of literature. And now having Gary and his team doing this in our institution, it's shame not to capitalize on it. And I'm slowly moving towards the fact to figure out the way, mutual collaborative effort to have Gary and his team helping my team and our colleagues win them on board and maybe broaden the indication for pain management. Why I think it's very important, as Gary pointed out, geriatric traumatic pain injury of utmost importance in lieu of comorbidities and drug-drug interactions and an ability to do so. One thing I just want to bring it up, and Gary, please support me on it. The procedure itself is fascinating because it provides this long-term pain relief at the expense of reduced morbidity. I wouldn't say mortality, reduced morbidity. However, we need to be very conscious of the fact that this blockade, this ice ball freezing of the nerve, can be detrimental to motor nerves. And if your whole goal, your idea of faster recovery after postoperative neo-hip replacements, right, or any traumatic lower upper extremity surgery, knocking off motor nerve, it's not going to be beneficial. That's why I believe primary use for this type of technology in therapy would be using against sensory nerve. And that's why intercostal nerves for the rib fractures could be, and got to collaborate to it, burns are very big on it. And what I came across to it, lower upper extremity burns, let's say lower extremity, lateral cutaneous femoral nerve, even anterior cutaneous femoral nerve. These are the nerves you should be able to neuralize, will give a great deal of weeks, if not months, of pain relief. And then based on additional predilection, what particular indication would be. I'm going to let Gary speak in a second, but I think maybe occipital headache with cervicalgia, occipital nerve block, right, is a sensory block, can benefit from it. So slowly but surely, there's a slew of painful syndromes that cryoneurologists might have a great deal of use in the emergency.
Yeah, and so Gary, I'll let you expand upon additional uses that you see. And one thing you did mention to me in our chat earlier this week was post-mastectomy pain syndrome with the intercostal brachial nerve. And that's a very compelling area of interest, certainly for the number of women that go through mastectomies or lumpectomies and that have axillary dissections, certainly that have nerve injury. So I'll let you go take it from there.
Yeah, so the post-mastectomy is one way you could use this device and this technology to attack painful syndromes. Post-mastectomy syndrome. Mastectomies are one of the most common surgeries performed in the United States, but I believe it's the top 3 for post-op chronic pain, which we don't normally think of. So it's that. There was a great study out by a team out in San Diego where they did intercostal brachial and intercostal nerve blocks on multiple nerves, and they decreased pain up to 3 months after the surgery and decreased opiates. As Sergey alluded to, it's approved for any peripheral nerve in the body. So we've used it in our pain office for occipital neuralgia. We've used it for postherpetic neuralgia, chronic rib pain after fractures and surgery. Some of the most common uses actually is going for superficial sensory genicular nerves, the lateral femoral cutaneous nerve, the anterior femoral cutaneous nerve, the infrapatellar branch of the saphenous, so you could numb the skin preoperatively before a painful surgery, a total knee replacement, or as we like to call it, a total knee arthroplasty, to reduce opiates, improve function, decrease length of stay. So you could attack any sensory nerve. So we've utilized that already in our private practice. We're trying to transition into the hospital to have everyone who gets a knee arthroplasty have this technology to decrease opiates, improve function, and recover faster, which is quite interesting and motivating for me because when I first started, we had a femoral catheter to block the motor femoral nerve or an epidural. Patients were in the hospital 3 to 5 days with the CPM machine, which is like a medieval torture device you might see in Mad Max, where you're kind of moving the patient's knee back and forth after surgery. And they were miserable taking PCAs, high-dose opiates, to now we're freezing these nerves beforehand, doing our nerve blocks in the operating room with long-acting local anesthetic, and they're going home same day with minimal or even no opiates sometimes.
And you're getting up to 3 months of relief in that setting, doing it as you described?
Yes, up to 3 months of relief, which is huge because most people or most patients recovering from a knee arthroplasty at about the 6 to 8 week mark, they have improved range of motion, they have their 110-degree flexion, they have their extension, and they're kind of getting back to their normal life. So you cover the whole post-operative rehab where they don't have to get recurring refills, they can participate in physical therapy. And I think as you two both know, part of the recovery process is just be able to interact with family and friends without being sleepy, angry, and pain all day so they can get back to their normal function.
Now, in terms of this procedure, would there be any increase in DVT in any relationship to this by chance?
Actually, less of a risk of DVT because they have less pain, so they can get up and move faster. Some of my surgical colleagues who have implemented this in their practice has gotten away from using, let's say, the stronger anticoagulation, like those Lorettos, the Coumadin, and they just give them baby aspirin post-operatively because their patients are going home the same day and walking. So it's actually probably safer for patients. There's no research out there yet to show that, but we all know the more you move and the more you're not lying around, the lower risk of having a DVT or a blood clot. And there are studies to show that there's no damage to blood vessels other than if you stick it with the needle, because the nitrogen gas in this that allows the ice ball to form does not get injected into the body. It's all resorbed in the machine. So the only thing the body sees is this ice ball, which if you hit a blood vessel would melt because we should be 98 degrees. The ice ball is negative 88 degrees. So there's no gas injected into the body either. So there's no risk of a gas embolism.
Yeah, that's what I was going to ask you about air emboli, but you perfectly led right into that. Now, in terms of training requirements, currently, what do you envision as a way we can train residents and fellows to do this? Is this currently something being considered in curriculum?
Yeah, so we are going to train our residents. First, I'm training the attendings. I think first, before you use this technology, you should have a basic understanding of ultrasound, how to use the device, the different settings, what are the risks for each procedure you're doing. Let's say, as Sergey alluded to, an intercostal nerve block, you could have a pneumothorax. So you have to be able to identify the rib, where the nerve should lie, the innermost intercostal muscle you could see on the newer ultrasounds, and where the pleural lies. So I think people should start with just basic ultrasound training and then advance to your typical intercostal nerve block. Once you could master that, the procedure with the device is not much different than an intercostal nerve block, except you have a handheld device in your hand and the needle is just as long as a pen. It's 3.5 inches. So if you could do a nerve block with a spinal needle, you could do the procedure. So once people have the technical ultrasound skills, Then they could advance to needle-based procedures. And once you have that training, you could use this procedure safely and efficaciously.
Right. Sergey, do you see this as requiring quite a bit of time and training in your program?
I mentioned earlier before we started that with the advent of ultrasound-guided nerve blocks, vast majority of the physicians are becoming very comfortable and fairly effective with maneuvering a needle and ultrasound and probe. And the learning curve is essentially the same. The only difference is, as Gary pointed out, some of the nerves could be new to ED folks, but the technique, the understanding, the visualization, and knowledge of anatomy, it's essentially the same. And as he pointed out, if you can use it with the spine under the local anesthetic, procedure becomes exactly the same. It's a slightly different trocar, different needle, and instead of local anesthetic, you use a gas at cold temperatures, and that's pretty much it.
Are there any other barriers to adoption in terms of cost, the device itself, the companies that manufacture these handheld devices?
Well, there's always cost associated with the new device and needles and the gas. Thankfully, they're covered by Medicare and CMS and most commercial insurances in the current framework, which I think is important. I think Congress is seeing the benefits of opiate-sparing that Sergey helped lead in the ED at AABP, and Maimonides were helped doing this intraoperatively as well. I think the government is seeing that. So there was a No Pain Act passed in 2023 that's starting in January 1st, 2025, that's going to allow certain approved companies, devices, medications to have to be repaid by CMS, Center for Medicare and Medicaid, in the hospital setting, in the outpatient departments, and in the inpatient surgical stays, so we could have less opiates. So I think that's important. So it is reimbursed now. Obviously, there is a cost associated. The other benefit of this procedure and these techniques is, as Sergey alluded to, it's done under ultrasound. So the way we all learn doing procedures, whether it be central lines, chest tubes, we learned a blind technique. There was no good way to practice. Or in my interventional pain practice, a lot of our original techniques were done under fluoroscopy, which we don't want to get extra radiation for practice. The benefit of ultrasound and the advent of handheld ultrasound devices is we could practice scanning and techniques on each other, on colleagues, without the fear of radiation, other than the fact we need to shower after the surgical lube is on from the scanning gel. You could practice your techniques in a safe way without harming a patient or yourself.
Absolutely. Do you see any role for possibly stellate ganglion blocks, certainly that are a little bit more risky and have greater depth?
So people are looking at different studies because, again, it's a needle-based technology. So we do a lot of stellate ganglion blocks. I have not done it for this procedure yet, but that's the next step of what I try, because under ultrasound, we could see the longest coli muscle. We could see the carotid artery. Obviously, we don't see the ganglion per se, but anatomically, we know where it lies. So you could drop a couple of lesions on there and give a theoretic prolonged sympathetic block, which might help with symptoms of CRPS. I know there's some studies that have looked at stellate for long COVID symptoms. Unfortunately, it looks like we're back in another wave right now. So I think that's the next step of the technology.
Absolutely. And I think, getting back to the emergency department, burns are something we see commonly, such painful conditions. So I think this is something that could really provide significant relief, especially with burns that involve the chest wall, not just extremity burns.
Yeah, I agree with you. Burns would be very good indication to utilize this technique. And just listening to you and Gary, another thing that pops into my head, which may have actually some science behind it. Any traumatic amputations, why not is done in a civilian environment or even in military, in a combat situation, right? You get injured a person who either upper or lower extremity is partially or completely severed or amputated, and pain is, God knows what it is, how bad it is, and probably, if not properly treated, is going to be a very long recovery. So that's our belief. In other percutaneous ultrasound-guided cryo-neurolysis will be very beneficial to freeze those nerves, allow the patient to recover through acute care, acute phases, rehabilitation, and move on with their lives.
Right. In the setting of, say, a painful distal radius fracture, femur fracture, things of that nature, Gary, do you see this as a modality in conjunction with emergency medicine colleagues as being something that's going to really become an important part of our armamentarium?
I do think it's going to become more important in the future as there's more studies to show what nerves you could block with cryo and longer term. I think you might see people start using these for fractures, especially for potentially fractures that are not operable at the time, or a patient needs to be optimized prior to surgery. As Sergey alluded to, it's optimal in burns. People have been looking for stump pain or post-amputation pain. There's a big researcher in Canada who's been looking at pain with spasticity for people with CP, post-stroke type of issues where they can't move and they have pain moving in extremity after these conditions. So I think we're at just the tip of the iceberg as to where people are going to use this handheld technology in the future.
We use long-acting nerve blocks for hip fractures already in the emergency department. So why not employ this technique, which, certainly I think would have longer effects and limit opiate use, as we all know.
And it might even help out a certain subset of the population. At least in Brooklyn, we have a large elderly population. I believe it's one of the oldest boroughs in the country, definitely New York. So there's some people that go on to surgery just because they might be bedbound, but it's the pain that is dictating their surgical procedure, not that they're ever going to walk again. So it's maybe the next step to look for. Maybe if you could block this nerve for 3 months or longer, that they're still going to be bedbound, but maybe you could avoid a surgical procedure that carries its own morbidity and mortality, which I see a big interest in the future.
Absolutely. And I think the idea behind treating spasticity is very important from an occupational therapy standpoint, eating, activities of daily living, just the basics. And so, getting someone's fingers released, being able to move their legs again, get them out of contractured states, I think that has a huge role.
Not only for the patient, but also for the caregivers. A lot of these patients, like if you're contracted fully and the pain from the spasticity is preventing your caregivers from moving you, it's difficult to put on a shirt, pants, everything, etc. One other point I'd like to make is that it's reproducible. It's not one and done. If the pain comes back from any of these conditions, you could treat again with another cryo treatment. And the current literature to date shows that it's just as effective time and time again, which I've seen clinically, that you could repeat this procedure, which some of our other procedures that we do in medicine are not as reproducible, which is important for some of these chronic conditions.
Now, you had mentioned earlier reimbursement. So currently this procedure is reimbursed on Medicare, Medicaid, and third-party payers, I assume.
Yes, not all, but a lot of commercial insurance, yes, for Medicare.
Reimbursement has to really be universal, because if this is shown to be more effective and limits opiate use, then there's no question in my mind that this is such a groundbreaking procedure. I'll let you both give a few pearls for our audience to summarize our discussion.
Well, my only pearl would be, that's something that I'd say somewhat long overdue, that this technique and the pain relieving modality should enter the emergency department. And with the auspices and a beautiful collaborative effort between emergency department folks and interventional anesthesiologists, pain management specialists, collaborative training, collaborative goal of improving patients' pain throughout the entire journey during the healthcare system, that would be my only pearl. Just reach out to your colleagues and within respective institutions who do you believe have aptitude, knowledge, and expertise. Reach out, get trained, and start passing down the knowledge to your faculty and by virtue of extension to your fellow residents and colleagues.
And Gary, I'll let you go.
He took the words right out of my mouth. Communication, collaboration is the two most important things. There's a shortage of physicians in this country. We can only each do so much. So we can each utilize, implement this technology to affect and help as many patients as possible, decrease the amount of opiates, help our patients, help our family members in our community live with decreased pain, improve their function, and just get back to their lives and keep on pushing the envelope of what's the next step in treatment. Again, like we went from giving opiates for this and that's it, maybe an epidural, maybe a 5 to 6 hour intercostal nerve block, to fascial plane blocks like Sergey said, to more advanced procedures, to now we can give months of relief. So I think just the communication, the collaboration, and just the camaraderie between our different specialties are important to push the envelope to help our patients.
Absolutely. And that's so well put. I completely agree. I want to thank both of you for a very lively discussion, very informative. Your expertise is greatly appreciated and will certainly benefit our audience. Thank you both again.